Greetings, everybody. Let's see, I've met Mohammed. Anybody else that wants to introduce themselves? I'm Dr. Bennett. I have some feedback here. So I must have a microphone open somewhere. Greetings, everybody. See, I've met Mohammed. Anybody else that wants to introduce themselves? Okay, I think I had two. Yes, hi. To whom am I speaking? Oh, Z, how you doing? So I must have a microphone open somewhere. Yeah, I had some feedback. I have so many things open here. Z, how you doing? Well, let me get that off first. To whom am I speaking? Oh, Z, how you? Okay, I gotta get these audios off. I don't need them. Can you hear me, Z? Z, you're muted. See, where are you, Z? Okay. You can unmute, Z. We could have a quick board meeting. Oh, okay. Hey, Juha.
Hello, John.
What,
so you remember, I will speak as in the last row.
Yeah. I know. Yeah.
Webinar. It was good that you sent me a message. I was totally confused. I was.
It's easy to get. It's easy. Yeah, it's easy to get confused with the time zone.
Minus or plus hours. So,
yeah. Well, we got lots of time. You can go at the end. The last talk.
Okay. Maybe Subin can begin, then he can translate.
Yeah. Okay. We can handle. We are a professional team.
Yeah, certainly. You are so experienced.
Okay.
Okay, let's do that.
I'll see you then.
We will join after Egypt.
Okay. Well, I'm going to see that. Yeah. How's everybody doing?
Hello.
Yeah, hi. To whom am I speaking? Keep calm. Mm. Welcome, everybody. We start in about 10 minutes. Hello, Ben.
Hello, John.
How you
Hi.
doing?
Fine.
Yeah,
So I can be the first speaker, no problem.
yeah, okay, that's good.
Yeah.
Because you know how it is. You get confused
Yeah,
with
yeah.
the conferences.
Yes.
And I just noticed. I looked at the because I know he's speaking in Egypt at 8 o'clock at the same time in a few minutes.
Uh-huh.
And then I said, "Wait a minute, ours starts at 8 o'clock." And then I said to Juha, but Juha was confused. But
Uh-huh.
it happens.
Yeah.
Okay, we start in 5 minutes.
Okay.
Yeah, I saw the Medtion. It was nice the way they put it. Let me show you. I don't know if you've looked at the page, but it looks quite nice. Okay, let me share the screen now. Oh, I've got to share a screen. Okay. Ben, look at this, the way they have it laid out here. See how nice it is?
Yeah. Yes.
It's very nice.
Yeah.
So let me get that off. Yeah, they're not afraid to publicize that.
Yeah.
Uh,
So every time, every weekend, we will organize a simultaneous translation.
yeah, that's.
Yeah.
I guess that's what makes it popular on medtion.com, right?
Yeah.
Yeah, he must like it because it gets people to watch.
Yeah.
I think because I'd like him to do other conferences of neurosurgery, but he doesn't seem to be interested. So, hello, Hugo. Good morning.
Hello, how are you?
Good. How you doing?
Good. Hi, Ben.
Hi, Hugo. So you're also in Zhengzhou?
No,
No.
tomorrow I'm
Okay.
flying back. Tomorrow I'm flying back.
Okay.
Finally. Yeah.
Okay, excuse me just a minute.
Hi, John.
Hello, how you doing?
Yeah, the first Zoom number is not correct. Yeah, on the flyer.
Hold on.
Yeah. So they send me the it's 826861459991.
Oh, okay. The flyer that I sent to who?
The flyer you sent it to me, the number is not correct.
Oh, okay.
Yeah.
Okay. Let me see here. Okay, let me check that.
Mm-hmm.
Well, people are coming in. It must be good for the people. Maybe I sent you a bad link. The other link seems to work. Maybe you have a bad link.
Yeah.
Okay, we're going to start in a minute. Okay.
Okay.
Let me let Dr. Lemming in. Hi, Dr. Lemming.
Hello, Professor.
Hey,
Yeah,
how you doing? I recognize you. Okay.
Hi.
thank you.
This is Ben Zhu. You know Ben probably.
Yeah. We know very well.
Okay, let me start now. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from Miami Beach, home of Neurosurgical TV. Gives me great pleasure to have another round of Juha's Neurosurgery Grand Rounds. And today, Ben Zhu is going to go first. Welcome, Ben. It's all yours.
Okay, thank you. So dear colleagues, dear friends, and today my topic is how to turn a negative into a positive using the reflux flow in the bypass procedure. So actually in the bypass, in anastomosis, sometimes the recipient vessel was like in the valley. It's in the circles and it's quite deep. So we can use temporal clips to elevate it to up on the surface. So then we can make it easy for anastomosis. Normally the monomer vessels are very thin and the vessel walls are very fragile. So it's almost transparent, and even under the biggest zoom, we couldn't recognize the vessel wall very well. So sometimes I use this technique. It's a special for the monomer anastomosis to left a small branch open to allow the slow reflux flow. So the reflux flow normally comes from the tiny perforators left unclamped on purpose by the operator, or sometimes a small perforator at the bottom of the recipient artery. The diameter is smaller than the thickness of the two vessel walls in the temporal clips, so it's still keep open. Normally, the reflux blood flow was considered as a negative, and in the traditional treatment anastomosing techniques, normally they will coagulate it and let it stop the reflux flow. But actually, I think this is we can turn this negative into a positive. Although the surgical field it's not very clean, and sometimes if the anastomosis is too slow, it may cause the thrombus. But we can resolve these problems. So we should challenge the new techniques, never be satisfied with the present. So how to turn a negative into a positive? Actually, I think the reflux flow sometimes is very helpful. With the help of the red blood in the middle of the cavity, the thin walls of the recipient artery shoot up even more clearly. A small amount of pressure causes the walls of the recipient artery to be separated so that it would not suturing to the opposite side. And if your assistant flush with the heparin saline, there's no chance for thrombus. It is almost certain that there will be no major bleeding after removal of the distal temporal clip. and left small perforators on the donor artery for final coagulation after removing the distal temporal clips. And the reflux flow would expel the air and the microthrombosis from the residual cavity around the stoma. So this is another advantage. So this is an example for this kind of technique. You can see there's some very small reflux flow in the recipient artery. So with the help of the red blood, you can see the vessel wall very clearly. And the small pressure of the reflux flow keeps the two layers of the recipient artery, the vessel walls, to separated. So it wouldn't anastomosis to the opposite side. And it's also helpful to keep the two, both the recipient artery and the donor arteries vessel wall in a without stitching. So this is the second side. Then you can remove the distal clip. You can see the vessel wall was very thin and there's still some leak. So I add another stitch to stop the bleeding. Actually, the recipient vessel wall was so thin that even the needle hole was bleeding. So I compressed with gel foam and wait. So you can see when the reflux flow from the recipient artery to the donor artery, it can expel the air and the microthrombus from the cavity. Use a very small power bipolar to coagulate the branches from the donor artery. So normally the needle holes stop bleeding need time to stop. So here it looks difficult to stop the bleeding, so I need some additional tissue. To bound outside of the stoma, and here stops the bleeding. Now the bleeding was almost stopped. Then I try to remove the proximal stapler clip. Now, after treat all the small branches on the donor artery, then remove the clip on the donor artery. But this is not stopped yet, because after you remove the donor arteries clip, you can see the pressure increased a lot, and the recipient artery expanded immediately. And you can see the diameter increased, maybe at least 20 to 30%. So with the increased pressure inside of the cavity, you can see it started a small bleeding again. So need additional stage. So in this moya versus anastomose, after removed the donor arteries temporal clip, you have to wait some time, and after the expandation of the recipient artery, you can observe enough time to make sure there's no further bleeding. Then you can stop. So now it all looks good. So this is another case. You can see the reflux flow from the small perforator. Actually, it's not so small flow. So you have to treat it fastly. So the assistant rings the heparin saline to prevent the thrombus in the vessel cavity. So you, with the help of the blood flow, actually you can see the vessel wall very clearly under the microscope. So actually, before you cut the recipient artery, you wouldn't know is there any reflux flow would happen. But if it happened, don't worry. You can just anastomose it as fast as you can, as possible. The another choice is to reclip the temporal clip. But if you change the position of the temporal clip, actually, it may cause bleeding and make the surgical field very ugly, and there would be a lot of blood on the surgical field. So this is my preferred treatment. I will let it keep reflux and then anastomose it as fast as you can. So this reflux pressure is is not very low. So when you remove before you remove the temporal clip, distal one, you can pretty sure there would be no bleeding, almost no bleeding happening. So there's only some small branch on the donor artery. Actually, this kind of bleeding can expel the air and the remnant, some microthrombus in the left cavity. So it's also helpful. Then remove the donor artery's temporal clip. So now you can see it's perfectly anastomosed. So after removing all the clips, the intravascular pressure in the recipient artery increased significantly as the first case. The diameter of the recipient artery increased immediately. In the first case, we can see it increased about 20 to 30%. So we have to wait and see if there's any bleeding after the diameter changes. And if there's some new bleeding, you should treat it directly. So sometimes we need some patch to stop the bleeding from the needle holes. So tie up like a lotus root. Like in this picture, I tied up some fat tissue on the needle hole. So last year, Professor Lenzino invited me to Mayo Clinic, and we have a cerebral bypass course And we also have visitors from other countries, from Italy. And this is in the Johnson Institute of India. I trained the India neurosurgeons for anastomosis. Thank you. That's all for today.
Okay, very good. Thank you very much, Ben. I'm going to turn this over to Hugo Andrada, neurosurgeon that works in Henan with Juha as well. He's originally from Venezuela. Welcome, Hugo.
Hello. That was a very good talk, Ben. I don't know
Thank
if
you.
the audience has questions or comment. Just wanted to ask you, how do you solve in the case that you have a thrombus inside the recipient artery or in between the donor artery and the recipient artery?
Actually, in my personal experience, it never happened. And because if your speed is fast enough and always keep rinsing the irrigation of the heparin saline, don't worry about it.
Mm-hmm. And I don't know, any other questions?
And you know, I also left some perforators on the donor artery, so it's on purpose to left it open. So after you removed the temporal clip, actually it can expel all the air and the microthrombus in the left cavity. And so then finally you can remove the donor artery's temporal clip.
Okay. And one question, have you used, in case that you have this small leakage, you always use gel foam, but have you
Yes,
used
sometimes if you use gel foam and if the diameter change, if the diameter enlarged a lot, actually sometimes you can see some new bleeding, and this time you maybe need additional tissue to bound outside of the stoma, like I already showed.
Yeah.
Use fat tissue and sometimes even electrode, the membrane is also very helpful to stop the bleeding. Yeah.
Have you ever used fibrin glue in case that you have
No, I never use it because I don't think it's very helpful. And sometimes I only used once, and actually it caused vasospasm.
Okay.
So it make me disappointed.
For example, I have once.
I stopped using it.
I had once and I use it. I just put a little bit of gel foam around and I just use the
Yeah,
fiber.
I just use gel foam and some sometimes the fat tissue or electrode membrane, and sometimes some muscle fibers.
Thank you very much.
Yeah, it's very useful to for help the hemostasis.
I don't know if the audience, they have questions.
Okay, if there's no comments or questions, Hugo, why don't you start your presentation? I'd like to welcome Clemens Schirmer from Geisinger. Hello, Clemens. Okay, Hugo, it's all yours.
Right. So just now, can you see my talk?
Yes.
So, thank you very much, John and Bean, for translating and organizing the seminar. So today I'm going to talk about the fully endoscopic transternal port approach. This is something that we described last year, and we're just going to talk about anatomy, technique, and the pilot surgical series. So a little bit about my background. I mentioned before, I'm originally from Venezuela, where I did my medical training and my neurosurgical training as well. And I'm currently working in Tenzhou in Henan province, and also I'm part of the neurosurgical research lab in Mannheim, Germany. So I had nothing to disclose. If we had seen like in the last decades, there's had been a tendency for minimal invasive microneurosurgery. And all these minimal invasive approaches towards the anterolateral skull base, they're based on the Terona approach that was described by Jasagil. We can see here just a picture of the Terona approach and how are these minimal invasive variants are just part of this. And we know, for example, the supraorbital approach, the mini-Terona approach, and the lateral supraorbital approach, they are mainly based on the Terona approach, and they have very standardized technique following microsurgical technique and under the microscope. But also we know that lately there has been an incorporation of the endoscope in transcranial surgery. And one of the main advantages of the endoscope is this an aid in visualization of hidden targets. You can use it as a complement tool in microsurgery, because then you can see the structures that are outside the microscope straight line outside. And also, if we think about it, the lateral supraorbital approach or this minimal invasive variants, they were not primarily described to be used with the endoscope. And also disadvantages for the endoscope are it because interrupted surgical flow. We know that they have standardized techniques, and then if you use a microscope and then you change to the endoscope, you're cutting your surgical flow. And also it requires a mental adaptation because you're working in the 3D or the stereoscopic vision from the microscope, and then you change to the 2D vision from the endoscope. Maybe nowadays with the new generation of endoscopes, you can have 3D images. However, it's not the same as stereoscopic vision. And also, if we talk a little bit of the cavernous sinus exposure, we know that it has been previously described by the Terona approach, bigger craniotomies, orbitozygomatic approach, or anteriotemporal approach. And there are a few reports that they describe access to the cavernous sinus and the skull base through minimal invasive variants, as we described in 2017, this the extended lateral supraorbital approach, or as described by Mura, the mini-Terona approach and extradural anterior clinodectomy. But until now, there's only a few reports of purely endoscopic techniques where they expose the cavernous sinus, and it's mainly based on cadaver studies. And there was no previous clinical application and so on. So therefore, we wanted to just create a purely endoscopic approach, transcranial, and this is what we did, and based on two pores incisions. You can see it. We did first in cadaver lab, and we have two incisions. The main working pore, that is this one. It's just a straight line behind the hairline. It's around 4 centimeters in length, and it's just below the superior temporal line, and it's just in length is 4 centimeters. And then this is what we call the main working point. And then we have a second pore where we place the endoscope, as you can see here in our drawing, that you can see you can place the endoscope through the supraorbital pore that is just a 0.5 or 5 millimeters skin incision, just a stab incision, and you can place your endoscope and mobilize in every direction. So this allows you to have a main working point similar to the endoscopic endonasal approaches, and where you can have bimanual work, and then your assistant is placing the endoscope through the other hole, and is allowing you to change the angles towards the surgical field. So the surgical technique is quite simple. So we just do the skin incision and detach the temporalis muscle and under the superior temporal line and just a little bit anterior. And the craniotomy or the burr hole is just placed on the lateral projection of the sphenoid wind. So we just place a burr hole there, and then we just do a craniotomy that is around 2 to 3 centimeters in diameter. And it's mainly a targeted craniotomy. You can see here. So the idea is that we just create a pocket in between the two incisions, just similar to the endoscope work or the endonasal work. So I'm just going to demonstrate one of our cases. This was a 73-year-old man with carotid cavernous fistulae. It failed endovascular treatment twice, and then they tried to do a supra orbital vein canalization and also failed. That's why we offer this treatment. So this is just the DSA. You can see the fistula here. Also lateral projection. So you can see here the positioning of the patient is just supine position with the head tilted 15 to 20 degrees towards the contralateral side. And as I mentioned here, we have the main working incision that's 4 centimeters in length, and then the stab incision just above the zygomatic process of the frontal bone. You can see here just the length of the incision, and you can see it's only 3.5 centimeters, but just do a pocket in between. And this is just a burr hole above or center over the lateral projection of the sphenoid vein. You can see we do everything endoscopically. This is just drilling of the sphenoid vein, the lesser and greater sphenoid vein. So until just exposed here, we have the frontal dura, temporal dura here. This is unroofing the periorbital, just detaching here, and this is just meningoorbital band. Then it's coagulating the meningoorbital band and then detaching this and just to peeling the lateral wall of the cavernous sinus. So this is done everything endoscopic. You can see here, this is the lateral wall of the cavernous sinus, just detaching the temporal dura propria from here. And this we use the navigation just to be sure that we're in the cavernous sinus. And we injected glue in between the divisions B1 and B2. We did also intraoperative DSA to assure that there was no presence on the fistula, and you can see here how much was the craniotomy size. So the procedure lasted around 2 or 3 hours, and this just the images that we had seen with all the names, and you can see here temporal dura, sphenoid vein, frontal dura, just the steps of the exposure. And this just followed the standard technique of the exposure of the cavernous sinus as it was described by Dolling a long time ago. So we also had done this for aneurysms, and this is just one of the first cases of the purely endoscopic treatment of intracranial aneurysms. You can see this was a 64 years old woman with a previous left rupture MCA aneurysm that she was clipped in 1977, and then she was reclipped in 1992. And then because of that, she was under surveillance for CTAs, and then we found a new aneurysm on the right side. And because of the previous history and risk factors, we decided to offer treatment on her MCA aneurysm. So we decided to go through the minimal invasive variant. And you can see, again, the main working channel, this is just in case that we need to convert the endoscopic approach to a microscopic approach. And as I mentioned, the second port where we place the endoscope here. So this is going to show you again the positioning. We always use navigation because we just place the craniotomy above the lateral projection of the sphenoid vein. So it allows you to have a more targeted view. This is just you can see here just detaching the muscle, the temporalis muscle, until expose the bone, and then we just perform a burr hole over the lateral projection of the sphenoid vein here. Just gonna show you a little bit more. Just the burr hole, the pocket that I mentioned before, and you can see all the drilling is done by the main surgeon using by manual work, like if it would be the microsurgical technique. And because we don't go to the skull base, we just limited our approach, and then we just open the dura in a curvilinear fashion. You can see here, frontal, temporal, then the dura can be retracted using a clip, or we can use some small patties, just roll patties, and then you can detach or use it as a self-retractor. You can see here the aneurysm, and you can see the view that you get with the endoscope. which is higher and more magnification than the proper microscope. So it's a remnant of the aneurysm and just placing the last clip. So the work is done a similar way by manual work with two hands, and the assistant is just mobilizing the endoscope. This is the same case. You can see the images and pre and post, and what is the quality of the aneurysm images that you get. So we published this last year, and we had 17 cases that time. And you can see what were our indications were MCA aneurysms, posterior communicating aneurysm, also cavernous fistula, and small tumors, small clinoidal tumors. And you can see among them, one of the patients we have to convert to a microscopic view because of injury of the carotid artery. And it was because during the endoscopic approach, there was an injury, an adverse injury of the carotid artery. So we had to convert it immediately to the microscopic view. And at the beginning of the series, it was done mainly through the one port, but then we realized with the two ports, you could easily mobilize the endoscope and get better angles. So then we changed to do everything in two ports. So the patients also, they report their scar as a good recovery without any scar problems. And only one patient has a chronic subdural hematoma 3 months after follow-up, and one of the patients developed temporalis muscle atrophy and discomfort. So what are the characteristics of our patients? Normally, we use this for patients with a wide sylvian fissure and basal cistern because of the limited maneuverability from the approach, and aneurysms that are along the carotid or middle cerebral artery axis. The problem is if you go to the A1 or ACON complex and so on, the work is more subfrontal, so it requires frontal retraction, which is difficult in this kind of settings with the endoscopic approach. Then in this case, you need a self-retainer retractor that it doesn't disturb you in your view. However, the trajectory towards the skull base, because it's mainly a targeted approach, is easier because all the work is done extradural. Aneurysms, there are small aneurysms that are not complex configuration because we're developing this technique, and then it requires more experience, and also tumor diameter less than 25 millimeters. Complex tumors you shouldn't do with this. And aneurysms are tumors that are not embedded on the brain, and tumors not encasing the vessels. Those were our surgical criteria. This is what we had done. Normally, when we have aneurysms, we do an MRI, and then we just see how is the sylvian fissure looking into these patients. So what is the evolution and rationale from endoscopic transcranial approach? We know the perceived advantages of minimal invasive approaches, and we know that minimal invasive approaches, they allowed us to get better cosmetic results, shorter in hospital stay, they are cheaper because of this, and so on. So we know the purely endoscopic or endoscopic assisted approach are conceived to provide a more targeted surgical route to the pathology, and this we had seen in our approach. And if we recall a little bit about history, yes, it's just a targeted approach, and however, it's still in development. We had seen is mainly based on cadaver studies, or this is one of the first surgical series about it. There was one in 1997. It was mainly done to the supraorbital approach. So we can say that our endoscopic transternal port approach follow the principles of the classic pterygium approach because it's centered over the pterion, and it requires sphenoid wind resection and drilling. And also it combines extradural anterior clinoidectomy that described by Dolan. We also base our approach from the previous description from Bean and Forlan, where they had this similar approach to extradural exposure of the cavernous sinus, but also we combine modern endoscopic skull-based surgery, and the principles are based in minimal entry surface with maximal inside or deep working space. So what are the advantages of our approach? safe manipulation, exposure of the temporal fossa, cavernous sinus, with minimal brain retraction and less invasive to the temporal muscle. And we know this because of minimal invasive approaches. And also it provides improved and clear endoscopic visualization of deep-seated and complex neurovascular structure of the cavernous sinus. We had seen, we went from 10 centimeters, 12 centimeter diameter craniotomy towards a 3 centimeters diameter craniotomy. And it allows you the transposition of basic concepts of endoscopic endonasal surgery. And we know this small approaches and maximal deep work. And also allows you, because of the second part, it also allows you multi-angle trajectory toward the anterior and middle cranial fossa, and also in both intradural, extradural space or exposure. And it can be used potentially as a complement of endoscopic endonasal approaches when the pathology extends towards the lateral skull base, and you can combine with these kind of approaches. This is just one example. You can see here the same aneurysm and how is the microscopic view, and you can see the quality of the endoscopic view. So it allows you to see around the corners, it allows you to see the perforators in a higher magnification too. So of course, like everything has limitations and complications. And one of the limitations is the limited superficial access. So it limits also your maneuverability and imposes more coaxial work or movement. It requires experience and adjustment because it's not something that is standardized like other approaches. So it needs time to go to the lab and try it again. And also the 2D visualization restricts the microsurgical handle of structures because we're so used to the stereoscopic vision of the microscope that changes to the 2D, or maybe nowadays we can solve this with the 3D endoscopes, but it requires also time. And also potential complications. As I mentioned before, we had one of the cases that it has an ICA injury. So it requires careful per-surgical planning because you need to see that the patient doesn't have any encasement of the artery and so on. And we need to apply this to the right patients, and we need awareness of the depth of the surgical field. And in sometimes in case that we have a complication, we should convert this approach. So what was always our idea was to go for the endoscopic approach, but we always prepare the microscope in case that something will happen. And in case that you have to repair an artery in a rush, or sometimes you require an emergency endovascular intervention. So as a conclusion, we can say the endoscopic port transference approach is based on the concept of small superficial access and wide deep bone exposure, similar to the principles of the endoscopic endonasal approaches. And it also provides a less invasive focus and direct route to the cavernous sinus, as well to the anterior cranial and middle cranial fossa, while avoiding extensive bony resection. And it's just an attempt to establish a cohesive and complete endoscopic transcranial technique. I just want to thank my friend and the mastermind behind this approach, Ivan Radovanovic, and thank you very much.
Okay, Hugo, thank you very much. Okay, comments or questions from the audience? Or you can put them in the chat. Go ahead.
Good morning. My name is Natalie. I am from Mexico. I want to know about the instruments that the doctor used for this approach. There are larger or different than the microscope instruments. It's the one question. And the other question is about what is the things that you do if you have a injury in carotid, for example. Do you do something special like put a cotton, or what do you do before to convert to the microscopic approach? Thanks.
So the endoscope is just a regular endoscope. It's an 18 millimeter endoscope. 18 centimeters is the one that we have been using, and it's a 0-degree angle. And the instruments, because it was everything in development, the only thing that we had for the endoscopic was the clip pliers. And in that case that we had the rupture, it was just we compressed the carotid artery with the cotton. intraoperative, and then we just convert it as far as possible. The good thing is you always have an assistant, so the pocket also allows you to work directly. You just need to open a little bit more the skin and so on.
Okay, thank you. More comments or questions before we move on? Okay, very good. Thank you, Hugo. Now, do you know Dr. Lemming, Dr. Zhao Lemming? Okay, why don't you introduce him?
All right, thank you very much. So today we have Chao Limin, is also a co-director of the Moya Moya department at the Henan Provincial People Hospital. He's a friend of ours, a colleague, and we work all of us together. And he's going to talk today about Moya Moya and intracranial aneurysms. All right.
Okay. Okay. Thank you, Albert Professor, and thank you, Hugo. Nice to meet you, my Professor Xubing. And thank you, Albert Professor, giving me us this chance to share our experience in the Moya Moya disease and some experience. Okay. Can you see me?
Yes.
Okay.
You want to make it bigger? Yeah, at the bottom, you can make the screen bigger.
Okay.
Yeah, perfect.
Okay, in normal, most of the people think the Moya Moya disease has a rare disease, disease, but in fact, Moya Moya disease have a high incidence in China, especially in Henan. From 2008, we always feel every year we can finish the 300 cases for two bypass. So from 2018, we built a new treatment center for Moya Moya. And in the last year, 2018, we finished over 1,000 cases for two surgery, and including more than 370 cases for two bypass. So because this year we know, because the epidemic in the first of the 2 months in this year, we have a little patient, but from the May and April, March, every month we can have over 30 cases for two bypass. So we have a big amount patient in Henan. We want to do more experience and research for two Moya Moya disease. And actually, most we know Moya Moya disease is this patient, the both sides IC and or AC is occlusion, and in the base of the brain have some unhealthy or neurovascular network vessels. And for the and there are two types of the Moya Moya disease. One type is hemorrhagic, and another is ischemic. For the adult, most of the person is hemorrhagic, and the young guys, most of is ischemic. So in our center, if the patient is come have SH or ventricle hemorrhagic, we always to check the CTA to find whether this patient have some problems in the vessel. And for the hemorrhagic Moya Moya disease, most people to think maybe because the new vessels for the Moya Moya, this Moya Moya vessels is very thin and very easy for to rupture. And another view is to think the hemorrhagic Moya Moya disease, because for this patient always have some aneurysm, maybe or minor main trunk artery have the big aneurysm, or have the miliary aneurysms, especially miliary aneurysms, because we know for the Moya Moya disease in the M3 or M4, always we can find some very small aneurysm. It is dangerous for this patient, because for the disease develop, it is have a high risk for rupture for the aneurysm. And for this aneurysm's location, in the before I check some papers to think the most of the aneurysm in the posterior circular arteries, because for the moyamoya disease, the both sides ICA or ACA is a collision, so the posterior circulation artery have a high blood pressure, and so in here always to have some aneurysm. But these days I found some papers to published. Actually, for the moyamoya disease, don't worry the aneurysm or moyamoya vessel, because that is artery tins. So most times in anterior circulation, always we can find some aneurysms. And for the aneurysm with the moyamoya disease, it can be over 3% to 14%. So if we found some patient with main tracheal aneurysm, we should deal with it early, because it is have a high risk. And but sometimes we can find some military arteries. So maybe after several months, maybe we can do the bypass. We can deal with this aneurysm. So for the moyamoya in clinical reduce, we can always find some cases for the moyamoya disease with ruptured aneurysm. We must to know what we should do for first, because if this patient is a ruptured aneurysm, we must to deal with it. And the next step for this patient, we must to deal with the ischemic, and to do next bypass. It is a good choice. And for some patients, we can find we must know that if this patient have the brain bleeding, or bleeding in the brain, the bleeding in the blood in the brain, we must know where is the blood from. It's from the aneurysm or moyamoya. If the blood from the moyamoya vessel, we must to waiting for 1 to 3 months for this patient to have a stable station. That's a good choice to do the next treatment. So for this patient, moyamoya with the aneurysm, don't worry whether we choose the clip this aneurysm or embolization this aneurysm. It is always have a high risk, because we know for operation we must to open the bone, and because for these people they have a very low for to record the ischemic, and for to choose the embolization, and we must to do some intravascular to do something. So that is always very difficult for this patient. And in our center, we always want to use one stage to deal with two problems. Use one operation to deal with the anterior circulation aneurysm with moyamoya vessels, because I think that is useful and very it is useful for this patient. So that's our opinion. In our opinion, we think that we must to know for the patient whether we should to deal with the hemorrhage, or we should to deal with the ischemic. If this patient have some aneurysm in the anterior circulation, so we can choose the clipping and bypass to deal with the two problem. But if the aneurysm in the posterior circulation, or maybe we can't choose embolization and bypass. But the aneurysm from the military aneurysm, maybe we just to do bypass is enough. And sometimes we have some patient is the moyamoya disease with unruptured aneurysm. So this time, for this patient, we should we should deal with this patient is ischemic. So bypass is we should do the first, and after bypass, this patient will high. We can to work something to more. For this patient, we always to choose a for this patient, we also choose improved approach bigger than before. And next, I will introduce some cases to finish the last month. Because actually in our center, every month we can to face one or two cases every month is more with aneurysm. So this is 38 years man. This patient have a hemorrhagic 3 months ago and to check CTA to find the more disease. And this time he hospital the check found the both ICA and the end of the ICA is occlusion and the base of the brain have some vessel, the vessels. But for this patient, we can find in the M1. In the M1 have a mid-3 artery. If in normal, maybe we can to think after bypass, maybe this aneurysm is occlusion, but we can find it is bigger than before, so we choose to clip it. For this patient, in the operation, we can find in the IC occlusion IC, we can find the MC and the ACA is occlusion, and in the ending have some more vessels. And the first step, we should to got the aneurysm, and the next to clip it. After clip, we should to use the ICG to check the vessels because it is very useful and to find the vascular position and the aneurysm clipping. After clip and use the flu 800 to check which vessel should fall to bypass. For this patient, we can find some vessels. Yeah, in here we can find the M1 to aneurysm. It's very small, but the vessels is very thin. And in the around the more aneurysm, we can find more vessels. And for this patient, we can find the AC and the MCA is occlusion. And this patient have a very strong PCOM. And first step, we should to very clear, easily and very softly for to separate the aneurysm. But we know for this patient, the aneurysm is very thin. So soft and slowly to clip it. Clip aneurysms and use the ICG to check again to find the whether we to broken other vessels. Because for this patient, we know moyamoya disease, it is first step is ischemic, so we must to have a high blood pressure. This is the CTA to check after the operation. We can find this is a clip, and in there is a bypass. And the next case is the 64 years old male. For this patient, he just have a headache, and in the MRI to find that is a moyamoya disease, and found anterior ACOM, the aneurysm. That is a DSA. But for this patient, he have a spical because this patient the right side the A1 is occlusion, but in for this patient have a 3 mass bench for to A2. So for this in the DIC we checked in the right side the A1 is occlusion, but actually in the operation we found we can find a very thin vessels is way A1. And the next step we must to check every A2. That is very important. Check the check all the vessels, we can to clip, because if we finish all the to face every A1 A2 and clip is more easy. After clip, we always use ICG to find which vessel we should to clip to bypass. And after bypass, we use ICG to check flow 800 again. That's this video. In the DIC, we can find the right side of the ICA is occlusion, and we can't find the A1. But actually, in the operation, we can't find it. And the next step to check every A2. In the DIC, we can find for this patient have a 3 bench for the A2. So in my opinion, that is very difficult to share every bench. So found this 3 bench, and the next choose to clip it. After clip, to use the ICG to check again. And the next, use the ICG to find to choose the vessels for to bypass. And sometimes in our clinical treatment, we also found to some more disease to with rupture the aneurysm. That is, we also to do the emerging surgery. For this patient is 43 years old man. This is have an emerging surgery because they have certainly bleeding in the brain. We can check the CT. We can find in the brain have more SH in the brain, and this is more disease with ACOM. Use the DSA, we can check this is more syndrome with ACOM aneurysm. So for this patient in our center, we always to use one operation to deal with aneurysm and for bypass. For this patient, we have more time to check the PWI to find the wall for this patient. So step 1 to clip it, clip the aneurysm, and the next step to bypass. This is a check CT and full bubble. And sometimes we can to find some patient is have aneurysm in the posterior celebration aneurysm and with the moya. So for this patient, it is difficult to clip, so we can to choose the embolization. For this patient, we can find both sides the ICA is occlusion, and in the bicycle artery and the left side ventral artery have aneurysm. So for this patient, we always to choose embolization. After the embolization, the aneurysm, and after one week, we choose bypass. That is post-embolization of DSA. But in the clinical treatment, we always to find some spical cases. Such as we can find the patient have the one side is a PCOM, but in the other side is a more MC or ACA or IC is occlusion. And sometimes we found the emerging surgery found in the MCA is in one side have MC middle cerebral artery have aneurysm, and the other side the middle cerebral artery is occlusion. So, and sometimes we can find some myomatosis with PC's aneurysm. So for this patient, we think for this patient we must to know we need to clearly the problem is to solve the what we want to do. We should to deal with bleeding or to deal with the ischemic. So that's give us whether we should to deal with the aneurysm or we should to deal with the ischemic photo bypass. Which one is the first step? And sometimes we can find some patient. We can got some patient have the aneurysm with ischemic. Maybe the aneurysm in the PCA, but in the P3 or P4, we can also to use operations to use the expanded approach and with subtemporal approach to deal with this aneurysm, and after deal with, we can to do the bypass. So for our center, our view, for this patient, we must to know what we want to deal with. We want to deal with the aneurysm, or we want to deal with the ischemic. For two monomer disease with rupture aneurysm, if this patient, the aneurysm in the anterior circulation, we always in our center we always use one stage to deal with the two problems. But if this patient, the bleeding from the monomer vessels, we must know where the bleeding from. Is it from the aneurysm or from the monomer? If from the monomer, we should to waiting for 1 to 3 months, because this patient should have a stable and after this time, maybe it is a good case to bypass. And monomer disease with the unruptured aneurysm, for this patient, we have more time to choose. So we can choose a clip, we can choose our embolization, and for this patient, we must know if we want to choose the clip or we choose the embolization. We must know this patient for the monomer disease. Most of people have the ischemic diagnosis. So in our center, I always to choose the bypass before to other treatment. So that is our view. Thank you very much.
All right. Yep. Thank you, Limin. I don't know if Bean wants to make some comments about it.
Excuse me, Hugo.
I think maybe Bean wants to comment on this topic.
Yeah. Actually, you presented a very nice cases with, but my suggestion is you should change the topic from the monomer disease to monomer vasculopathy, because actually there's a lot of monomer syndromes in your case series. It's not a typical monomer disease. And actually, normally the monomer disease in my personal series, I only have less than 20 cases with main trunk ACA or MCA aneurysms need direct clipping. So actually, sometimes especially the MCA aneurysm, you should be very careful, because sometimes it's just a blind point of superior trunk or inferior trunk of the occluded blind point. So sometimes it can be misleaded, like a small aneurysm. And when you dissect it, actually it's in the vessel cavity. Actually, it's not a typical aneurysm, and it don't need to direct clip. And mostly it's a peripheral, very small. Actually, it's after hemorrhage. After the hemorrhage was totally absorbed, maybe after 6 months, or 3 to 6 months, if you redo the angiogram, actually most of the small aneurysms would disappear because it's just a sign of hemorrhage immediately after the bleeding. So sometimes this kind of small minimal aneurysm don't need to be treated. Yeah, this is a typical moyamoyas. But actually for moyamoya syndromes, maybe the main trunk aneurysm is more common and need sometimes if the bleeding was caused by the aneurysm, it needed to be directly treated to clip it.
Just
Which I would agree with your opinion.
one question for both of you. For example, Bin, if you have let's say a rupture of aneurysm and you have moyamoya, will you still go, like, you clip the aneurysm, but will you still go for a bypass even that you know that you could have vasospasm later on?
Yes, in your hospital, in Henan People's Henan Province People's Hospital, you may have more emergency case than us because Henan Province has so many population, and you may have much more emergency case than us in Shanghai. So most of the patients come to my clinic. Normally, they already have treated some like drainage of the ventricle drainage after 3 months, and then they will find me to further treatment.
No, I mean,
but emergency, I have much less emergency case.
No, but I mean, if you have a rupture aneurysm and then the patient has moya disease, do you still do the bypass even knowing that that you could have vasospasm later? Because of
yeah, actually, if you can clip it directly, you can do the bypass immediately, no problem.
Okay.
Because it's a low flow bypass, the pressure change was not so much, so no problem.
So you don't get scared about the vasospasm and also manipulation of the vessels and so on.
No problem. Yeah, if it's normally I have treated this kind of. It's not in the emergency phase. It's only it's already after the subarachnoid node hemorrhage, maybe three months later. I treated this kind of patients, maybe around 20 cases. I always clipped the aneurysm directly and combined with STM-CA bypass.
Okay.
At the same phase. Yeah.
Right. Thank you. Any questions from the audience? Yeah, Professor Iboa.
Thank you. Good morning, everybody.
Hi.
One question to Professor Limin, Thao Limin, and also Bin Shu. Is different the moyamoya syndrome to moyamoya disease? Is totally different.
Yes.
The moyamoya syndrome, the case present, Professor Thao, is a stenosis of the vessel, middle artery, and you have the collateral circulation. And this type of associated aneurysm, many, in my opinion, is secondary to hemodynamic change, flow change. And when you is at the same of the associated aneurysms hemodynamic in AVM. Sometimes when you close the AVM, this aneurysm reduce or disappear. And the comment is why you treated the patient with a bypass and you wait, it's possible this aneurysm disappear. And the second comment is in moyamoya disease, sometimes you are deep aneurysms in lenticulostriate artery. To treat this is the complex situation. And to treat the deep lenticulostriate artery aneurysms, in my experience, the only device to use is a glue. Not possible to coiling, not possible in surgery. Finally, to resume, syndrome, Moya-Moya, associated aneurysm is hemodynamic. Moya-Moya disease, the aneurysm most frequent is a deep lenticular aneurysm. What do you think about my comment?
Yes, I agree with you, Ivo. Actually, normally, if you found the small, very small, isolated, actually you can find the isolated small aneurysm. It doesn't belong to any main branch of the ICA. Actually, this kind of aneurysm can disappear normally after you wait several months. So this kind of peripheral aneurysm don't need to be treated immediately. Just wait and do the bypass directly, no problem. And I agree with you for some Moya-Moya syndromes like MCA and occlusion with ACAM aneurysm. Actually, it's caused some increased collateral flow from ACA, and it's a hemodynamic related aneurysm. But if you do the open surgery for the bypass, why not clip it to the same surgery? So it's not a big problem for us. Just actually, in the same operation, it's quite easy for us to treat it actually. So don't need to treat separately and wait for the healing of the aneurysm. Actually, this kind of aneurysm couldn't be healing directly by itself.
Yes, the patient is a rupture aneurysm. Also, when you place the bypass, at the same time you clip the aneurysm. Also, this is important. The question is is not bleed the patient, and the aneurysm is in another vessel, posterior communicant the another side or whatever you want. This is the comment. Okay, thank you.
Yeah, you're welcome.
Right. Thank you very much.
Okay, very good. Hugo, I'll introduce Louis, okay, because I kind of know him a little bit. Yeah, I'd like to introduce Louis Lopez Ibor. I met him about 4 or 5 years ago. We televised his neurointerventional radiology conference from Madrid. And let me just take a second here and show it here, which I highly suggest going to. Louis, what day is it this year?
下面的讲者是 Luis
Yes, I think it's
Ivo.
16 and 17 January.
17. Yeah, I highly recommend it. It's a real Madrid experience. Louis, it brings you to the Prado, and you're right in the heart of the beautiful part of Madrid. So welcome, Louis. It's all yours.
Yes. You're invited, everybody. The problem this year is the aforo is limited because the problematic coronavirus situation. Is better, but is limited only to the speaker.
Okay.
But it's better. I need you help me with the.
Yeah, we can do a virtual conference. Sure, sure.
And is this year is a small group, no more 20 professors. And the ambience is Professor Bean come the last year. The ambience is particular because it's possible to stop the talk and the discuss and put many questions. Is the same or another yes?
Okay, Luis, on to your presentation.
Okay. I use the open. Just a minute. Okay. Okay.
You'll get it.
Now is compartir. And now is compartir.
There we go. Making progress.
It's okay, no?
Yes, perfect.
Okay. I present some case and different technique to treat the high flow fistula, pial fistula, also one case of high flow fistula associated to AVM or intranadal fistula. Okay. The first case is a young patient boy. He comes from Lamu Asline from Kenya. 7-year-old, present a posterior fossa syndrome, disorder to work balance, uncontrollable headaches, and not pair. This is a CT scanner from Kenya, 3D reconstruction, and this. It's important to see the fistula. You are straight sinus. You are falcial sinus, the same of the vein of Galen. One cortical vein, but the vertebral is dilated, but the posterior communicante artery is normal. In the 3D reconstruction, you have the polygon of Willis is normal, and this is the fistula. This is important to see this, because it's not Galen lesion. This is the MR. You have the mass effect of the vein in the brainstem. This is MR, angio-MR, magnetic resonance, when you see perfect the dilatation of the vertebral, the fistula, but the posterior cerebral artery is normal, and middle cerebral artery. Okay, the patient have a hydrocephalus at the same time. And don't treat this. Only treat the fistula, and this reduce the volume. At the same of the vein of Galen. Is described with my mentor Las Juniors. This is right vertebral artery, AP view. This is the vein, the sac, the pouch, and this is what is this is complex to understand. When you inject the left vertebral artery, you don't see never the basilar trunk. What is this? This is the point of fistula. What is this? No, never you see the basilar trunk. Lateral view is complex. You have the straight sinus with stenosis. You have the falcial sinus. This is occipital. This is occipital. when I inject the carotid artery, left, you see the reflux in the basilar artery going to the fistula. And you see very well the polygon of Willis. The only change is the hydrocephalia. I decide to perform double injection at the same time in the vertebral left and vertebral right, and also in the carotid artery and the vertebral artery. Why? Because I understand this segment is the distal part of the vertebral, V3. This is the point of fistula, here. And when I have this information, I decide to treat it with this technique is put one balloon in the basilar artery to protect. The basilar artery is in this position of proximality. And then close, this is the lateral view to understand better. Carotid, posterior communicante, basilar artery, fistula. I decide to place one balloon here and with another catheter, place the coiling in the distal part of the vertebral artery and the point of the fistula. This is an AP view, balloon, the second catheter in fistula. The balloon is here. This is the coiling, coiling, coiling. This is a control, totally occluded. Control in the carotid, ya no hay inversion of flow. The patient have a breakthrough syndrome about 3 or 4 weeks, but slowly go well. And this is in Real Madrid stadium after treatment, 1 month later. And this is 1 year later. Okay. This is another case. It's a woman of 45-year-old or 55. It's a similar case, a very close case. But the difference is a lateral view in the right carotid, right vertebral and left. You are a secondary collateral circulation going to the ports, the vein. It's the same in the vein of Galen fistula. The high flow, Bernoulli, by Bernoulli hypothesis, theory, sorry, the high flow here developed a collateral circulation. In this case, to treat it, the problem is the distance of the fistula to the posterior cerebral artery, and this is another branch, and you are also here one wall problem in the vessel. This is very fragile to rupture. I decide to use this technique. This is in lateral view and this is in AP view. AP view, I place one catheter in the sac of fistula. And the second catheter to place one device is this device. Is a Uno device is set at the same of filter, of carotid filter to stop flow and inject the glue. This is calcification of the wall of the sac. But to inject the glue, you need to inject the glue without pure glue. Very high concentration of glue, only 5 milliliters of lipiodol, only this to see. But the problem is you need to push high quantity of glue. Double injection with 2 syringes. This is the device UFNO. This is the glue, 5 cc of glue. This is a stagnation of contrast. Post-embolization, disappear the fistula. Still some remnant in the collateral circulation of posterior pica and leptomeningeal anastomosis post superior cerebral artery. This is the scanner in angio suite. You see the glue in a pouch, a sac, and the vessel. This is the device, UNO device. 6 months later, the control. And the still some remnant, the collateral circulation. I catheterize this to check. This is 2 years later. This remnant only to the parenchyma, is not to the vein, but because the fistula is totally closed. I study with the microcatheter this, EP view, only with the microcatheter in proximal or distal, don't have the fistula. It's a parenchyma, normal parenchyma. Normal anastomosis. Other case to check what is the problem when you close the fistula. Sometimes you have the breakthrough. This is a AVM, AP view, lateral view. This is a nidus, and this is the high flow fistula. When you place the catheter, sometimes a doctor place the catheter here. No, it's better to put the more proximal. And in this part, you injected the glue, pure glue. See, sometimes you need a pressure or technique, or my name is Danbeaver technique, is to place the coil in to stop the flow. Second catheter is still at the same time in the branch of nidus. The first is in the branch of the fistula. This is the glue. It's not very opacified because don't have lipiodol, it's pure glue. This is a coil to stop flow, and this is the fill to inject the fistula. After first embolization, 1 week later, the patient developed syndrome, hemiparesia, and headaches, and this is edema around the fistula to change the hemodynamic change, secondary close the fistula. This is evolution, and this is the final control with glued, onyx, sorry, and the glue of fistula. And this is a control 4 years later with angio. It's totally occluded. This is the onyx. totally occluded, the fistula. And the final case is why another technique I use the balloon. A septal balloon is to close, the stop with balloon the feeder. Why? This fistula, lateral view, the vessel is here. This is the collateral circulation in AP view. When you inject, the distance of the parent vessel to the fistula is very short. This catheter is in the nidus, in the pulse, in the vein. With arterial approach, it's in the vein. But the distance here is very small, and this branch is normal. This is the reason to put, I decided also to put one stent to stop here, but don't work well. And finally, I decide this is the injection, rod mapping. Here you have the second catheter. This is in the pouch, in the fistula. This is the normal branch. And this is a balloon, a septal balloon. After embolize, totally occluded the fistula. Some picture. This picture is better to see the balloon. The balloon is here. You are a second catheter here. You inject the glue here. You stop the flow here, and you preserve this branch. And this is the control. Totally occluded. Collateral circulation. Still patent the branch. This is a technique. Look, in lateral view, the branch is still patent and without symptom EQ in AP view. This is my presentation to what is my technical device to use in different high flow or PL fistula. Thank you for your attention.
Okay, Hugo, take over.
Yeah, thank you very much, Professor Lopez-Ibor. Those are amazing cases. If the audience have any questions about the cases or anything that you would like to ask to Professor Lopez-Ibor.
Silence.
No, Hugo, I have some case from Venezuela.
Yeah.
Because I sometimes I'm going to Venezuela, not now, before to treat it. I have some case of tremendous monster fistula of the, maybe another time I present.
Yeah.
A baby 7 months.
Wow.
It's incredible. The fistula, this is my final comment. The risk of treating the fistula is the phenomenon of breakthrough. Prevent this is very, very, very complex. It's not, when a pair is very complex. And this, I learned this with when I work with the juniors in the vein of Galen. And this, don't discuss everybody from this because it's very problematic etiology and pathogeny of this.
Okay, very good. Thank you very much, Louis. Hugo, could you, Juha is here, so could you please introduce Juha?
So the next speaker and the last one is my friend and mentor and colleague, a very well-known neurosurgeon, or how his professor used to say, one of the best ones in the world. I'll just let you with Professor Hernesniemi or Juha Hernesniemi. So he will talk today about ICA aneurysms, I think.
A1.
A1 aneurysms, yeah. He was busy with another webinar, so now that's why he was the last one today. All right. Thank you very much, Professor. Welcome.
Thank you, dear colleagues. I came back now from Egyptian and African webinar, so I will go to my presentation. I will speak about A1, anterior cerebral artery aneurysms. Can I have I will take my presentation. Okay, so surgery of A1 aneurysms, and working now at Henan Provincial People's Hospital since more than 2 years. Before that, around the world after my retirement in Helsinki 2015, end of 2015. So this is the background of the speaking about aneurysm. This is one of the best documented aneurysm series in the world, good databases with all information possible, extremely good follow-up of more than 18,000 patients with more than 22,000 aneurysms, and different sites. ACAM aneurysms form, this is the former like treatment method. I always show that it is nearly 70 years ago when you were ligating the aneurysm with silk ligature and adding some clip. In this case, it is Oliver Kruna clip. So these are the site of aneurysms in our databases, so more than 22,000 aneurysms. So you see that you should maybe count these A1 aneurysms. They are in the big classifications, belong to anterior communicating arteries, so this is 22%. Actually, they are rather rare aneurysms, only few percentage of all possible aneurysms. So there we have published all the sites of these aneurysms. You can find in PubMed, you can find also publication on A1 aneurysms, and they are rather rare, mainly saccular, but some of them are dissecting. Usually they are small, seldom even medium-sized. And what is important here, they are close to the perforating branches, so to preserve these perforating branches is extremely important in treating these cases. Because it's these perforating branches, and they are difficult to treat, and of course, in the case of dissecting aneurysms, there are difficulties to preserve the perforatosis, crucial, otherwise you will have severe hemi syndrome complications. So because of the close relation to the perforators, so you might have complications, hemi syndrome, and it is crucial to save these perforators. CT angio is a good diagnostic method in treating this, in diagnosing this CT. These aneurysms, what we learned in a small hospital like Helsinki, we made CT in the case of acute headache. If there was subarachnoid hemorrhage, immediately should contrast intravenously, and in 15 minutes we had beautiful pictures, and we could go immediately to operation room. Main part of the cases were operated on the same or next day of the bleeding. About the surgery, you can have here very well proximal control you can put proximally on A1 temporary clip, but also distally on the other side of the aneurysm, like we will see in the videos. If you have difficulties to put a temporary clip on A1, if the aneurysm is so close to the bifurcation, you can close also ICA, but this is seldom needed that way. And like mentioned many times, you have different surgeries. You have elective in unruptured cases, then acute in ruptured cases, the operation happening on the day of bleeding or next day of the bleeding. You seldom have large intracerebral hematomas in these cases. And then, of course, also, as mentioned, large giant fusiform aneurysms are extremely rare in this location. To good planning of the surgery, you can do it fast based on experience. You have to see how is the patient, what are the comorbidities of the patient besides the bleeding severity, age, size of the aneurysm, type of the aneurysm, and so on. So you have to assess the patient, the bleeding rate, and the aneurysm itself. I usually like to have the head elevated clearly above the cardiac level to lessen the bleedings, slight rotation of the head, and have a good, comfortable working angle. I operate always when standing. I don't like sitting because you cannot move so fast. I like to move very fast during surgery and change the angle, and also ask the anesthetic side to elevate or lower the head. In this way, I can change the angle to the aneurysm, and I'm using mouth switch in the microscope. This means that I can change also very quickly the microscope position, and this happens best when you are standing. So this is the craniotomy I'm using. Have been used since 80s in thousands of cases. Lateral supraorbital approach, minimal shaving, never taking all the hair of the patient, and then local anesthesia, single layer flap. With this way you have no temporal muscle atrophy and never frontal facial branch injury. You go subfrontally here after opening the dura, and sometimes it might be helpful to open proximally the sylvian fissure coming along M1 to carotid bifurcation, or other way, you go rather directly to internal carotid artery bifurcation, and then you will find A1, and this way you are doing well. When you have red angry swollen brain after fresh subarachnoid hemorrhage, you have to change this situation. You have to have slack brain. This is extremely important when doing microsurgery in cerebral aneurysms. I used to go to lamina terminalis, open it, then I have a flush of CSF, and then the brain is slack. Good neural anesthesia helps immensely. So this is one of the most important part of the team. Some surgeons are using ventriculostomy. I like to go to lamina terminals even through very small gap, because I can see what I'm doing. So sometimes you may fail with ventriculostomy. So I go to the videos now. This is from Helsinki. This should be the unruptured right A1 aneurysm. It's good to show always unruptured aneurysm, because then you see the surgical technique. You saw the aneurysm, And now this is the right-sided lateral supraorbital approach. Sukita hooks, and then you, with one burr hole, I make the lateral supraorbital approach. And then drilling down bone to the orbital roof, so you don't have to retract very much the frontal lobe, opening the dura, some stitches to fix the dura, and then you go subfrontally. Release CSF, some venous bleeding here. Then you see that I'm operating under high magnification because the microschizos look so huge, like a big crocodile going there. Cutting the arachnoid bands. And now we are coming to A1. We went directly, we see the unruptured aneurysm here. And what is here important, we see a very large striate artery coming close to the base. Now I'm not using here, usually I didn't use any retractors, but here in China I've begun to use because there are many things different than in my former operation room. So now the first clip is on the base of the aneurysm. Some hemostat here going. I'm doing hemostasis now. I think I should check better the position of the clip, but it seems that I was happy with that. And so now this is, I was happy in this case. Yeah, it was clear situation. So we go to the next one. It was more complicated. So, but you saw that there was a big perforator coming close to the base of the aneurysm. So this is ruptured A1 segment aneurysm. You see severe subarachnoid hemorrhage, operation in the second day after bleeding, many times also on the same day after bleeding. This is CT angio. This is the 3 dots I make, and then a short line in the hairline. Again, right lateral supraorbital approach, incision to the bone, and you see the red angry swollen brain, good anesthesia. Then I go through a small cap subfrontally, basal cisterns full of blood. A sharp dissection. I think I should go to lamina terminalis now, but I put the first, one of the tricks here, the aneurysm is on the way right there. So I put temporary clip on the A1, and now it seems that I have enough space. You see this is under the schizos, here is the aneurysm, and then the perforating branch close to the aneurysm. So this is the first clip going there. I'm cleaning the anatomy, a lot of blood, and then put second clip proximal to the first one. Temporary clip is still on the place. Take the first pilot clip out and then dissect more. I add one. Now I have 2 temporary clips. Yeah. So I want to have the clip position better. Dissect the striate artery carefully. Now it is empty because there are temporary clips on the both sides. So coagulate down the aneurysm. This is ice hockey. No, this, yeah, it seems to be ice hockey bipolar forceps, and then take a curved clip to have, and smaller clip to have it exactly on the base of the aneurysm, and add 1 clip more to have all the base taken, and remove the temporary clips with golden color. And now checking with Doppler, also the striate artery, and ICG shows that the small striate artery is open, and aneurysm, of course, it is coagulated down, so can certainly no more fill. Papaverine to reduce the manipulation spasm, and I leave papaverine on the place in the surgery chair. More papaverine, striking the artery. And now I, after opening of the clipping of the annulus, I opened the lamina terminalis, and because the brain was angry swollen, so I had put the catheter inside the 3rd ventricle for measurement of the intracerebral pressure and the release of CSF in the ICU when needed. So this is the situation, CT angio after operation. And there's one more case. This is a recent case from here in Provincial People's Hospital. So this is unruptured aneurysm operated in August. This is the operation, and this is the angio. You see the small unruptured A1 aneurysm. Again, LSO approach similar to Helsinki times, and now it is unruptured aneurysm, so the brain is clean looking. I open with needle proximal sylvian fissure, dissect with scissors, and goal is to come to the carotid bifurcation, and medially of that you will have the A1 and its aneurysm. Now we are at the carotid bifurcation. You see that I put a retractor here. This one I didn't do in Helsinki, but maybe it was such a big flow of operations, 15 cases a week, so I was better used to do surgery than with by far less cases now. So now with 1 temporary clip proximally on A1, and now there was a big perforator close to the aneurysm. Now the small mini clip is going, and now taking the temporary clip out carefully, slowly, and then checking the situation. The small but important perforator is there. And now we should do DSA, some hemostasis, but maybe we have done already. This is the ICG. ICG, I meant that this is ICG with rather low magnification, and this is supposed to protect picture, cleaned a good looking CT, and the patient made good recovery. So these aneurysms are rather rare. I didn't have any video of dissecting aneurysm. Of course, they are more difficult to treat. If discussing these aneurysms, you can add in the discussion, you have to be very careful with clipping, because many times from the base or close to the base of the aneurysm, there is an important perforator, and you might have a hemisyndrome when occluding that. So once more, I always repeat, to be a highest level of neurosurgery, you should learn English, because this means that you can publish your wonderful cases, many cases here in China in the international journals, and you will do better with the international connections. And once more, don't save the beautiful Chinese hair. Make here also minimal invasive surgery, make focused minimal invasive haircut, like in this young girl, parietal avium. Don't shave the head. You can take also according to the big incision, just shave the hair along the incision line, and you can shave beautiful hair. So there's a lot of contrast in China against opening of the head. I think we should, as neurosurgeons, we can do safe opening of the head, and those who cannot, they should not do neurosurgery. To open the head is not dangerous. What you are doing at the goal, this is crucial and most important for the outcome of the patient. I still think that the perfect clip at the base of the aneurysms remains best treatment for aneurysms, whatever is coming in endovascular surgery. It has long-term extremely good effect, and the recurrences are extremely rare. But to have the perfect clip at the place is difficult and needs long time training. So good teamwork, extremely important. This is from Henan Provincial People's Hospital, extremely good team doing surgery, and with the same setup like I had in Helsinki in my times as a chairman there. So thank you very much. Kiitos, seisei. So this was my presentation on the rare A1 aneurysms.
Okay, Hugo.
Yeah, thank you very much, Professor. Like always, extremely good. I don't know if the audience have questions. I think I saw one from the Harshad. How long do you put temporary clip, and do you use any brain protection during temporary clip?
In former times, this is long time. This 70s or beginning of 80s, we used to increase the blood pressure before putting the temporary clip, but then we gave up because it is so short time usually the temporary clip. So it is you should. Some people are asking to count. So I don't like, because if you hear 1 minute, 2 minutes, 3 minutes, it's disturbing your surgery. Main thing is that you do your work well, and usually when you concentrate on the work, you are doing rather fast. So it is seldom more than 5 minutes. Of course, there are extreme situations when the aneurysm ruptured and you have difficulties, but usually you can do it in less than 5 minutes. I don't think there are complications associated. That I always think nowadays the neurologists or endovascular surgeons are treating the patient with basilar artery thrombosis, middle cerebral artery thrombosis. In these cases, the artery has been occluded many hours usually, or at least 1 hour before the treatment. So it is, I think if we make 5 minutes, 7 minutes or 8 minutes, it is not big difference there. Depends, of course, on the artery. Middle cerebral arteries, end artery, and basilar artery has many collaterals, like carotid artery also. It depends on the artery, but 5 minutes is always safe.
Thank you.
5 minutes is a long time. Many people can run more than 1 mile in that time. So.
All right, thank you. Any other questions in the audience? Nope. Is there any comments from Professor Lopez Ibor or Bin?
No, no comment, because it's fantastic, the technique of Professor Hendriniemi. It's impossible to comment. the only small comment is, I agree with you, Juha. It's important the technique and learn beyond, the anatomy and the technique. Laboratory is important. Is the critical to endovascular is not to the endovascular technique. It's an endovascular surgeon. You are expert endovascular neurosurgeon, or example Moret or Bernstein, whatever you want. It's a good doctor. But the endovascular surgeon around the world sometimes is not expert, learn very quickly, and don't know well the technique or the anatomy. And this is the reason, because are the complication or recanalization or bad result. It's important to compare the best endovascular surgeon with the best neurosurgeon, to compare she really are what is the point of difference, what is the choice, is my comment.
Yeah, of course, the learning curve is extremely short in endovascular surgery. You can push coils or stents after having been 1 year in endovascular surgery, but you can never go to the basilar tip or carotid tip to clip the aneurysm with that kind of experience. You need a long training period, and this might be very difficult to realize nowadays, because the young people want to do something. So the learning curve is very long, and it takes many years to come to high level. It needs a lot of laboratory training, cadaver training, and to come with open microsurgery to the level you can treating the same disease. But I think this is one of the problems, and difficult to solve. So it is in every society is different, but also the same problems are there.
Yes, but the new generation, example, Dr. Andrade, is very thing because present the new device, a new approach, or new technique to neurosurgeon, to surgery of aneurysm. The problem is now in my country, in Spain, I don't have many expert neurosurgeons to treat the aneurysm. This is the problem. I need the neurosurgeon, neurovascular surgeon, the good. I need in Spain, I need in Italy, I need in wherever you want.
And of course, Madrid is a big city, so you could centralize, or Spain is a big country, you can centralize the cases, but this is always to centralize is very difficult because the people want to do themselves, so it is very difficult to organize. But if you have that kind of, like in some countries, there's national institute, so politics is involved, so you might get difficult cases treated in one institute. In China it is solved. Many people want to go to Beijing or Shanghai to the best treatment, so this is traditionally so you will find the best treatment there. Of course it is in all China you have great neurosurgeons, and in the bigger cities you have high-level neurosurgeons, so you can find also locally good neurosurgery. But of course, if you have many cases, so the skills are improving, and if you have extremely high number of cases, like you've been doing bypasses or other aneurysms, so huge experience that can never be achieved in any other places. I think in Europe it is difficult. There are so many small centers, neurosurgical centers, and then when competing with endovascular or open microsurgery, so the cases are so few in every hand. So it is now hybrid neurosurgeons are trained, so this might be one of the solutions, but there also big competition. Chubin has been trained in both, I think. Yeah, he's doing both. And in my center, there is also neurosurgeons who are doing both. So, but usually it is so you go on some site, you begin to do something, not 50-50 or. This might be one solution, but in Europe, the difficulty is there are so many centers and the flow of aneurysms is so small. And then when you divide, you are doing 2/3 by endovascular and then 1/3 by microsurgery. This means that even in big centers like Helsinki nowadays, so you will operate only one case a week when you are doing 65% endovascular now. So it means that and then when this is shared by 6 neurosurgeons, this number, so it means that you have a big threshold to operate on. I think to open the head, you have a more threshold than to push a catheter inside the human body. So threshold to open the head is bigger than to go transfemoral or transradial to inside the arteries. I think this is one of the psychological differences.
Totally. And Dr. Binshu is from another planet because you. No, it's incredible. No, it's incredible. It's your precision to the anastomosis, to work this anastomosis. Yeah, I have many questions, but I prefer to learn, and when I learn a little bit, probably I put the question because I like this surgery, and for me it's very important to complex aneurysm.
Yeah,
it's not only
complex aneurysm sometimes still need the bypass.
Yes.
Yeah.
I know what is the name of the what time come to Madrid, the bypass Elana
Yeah.
from
Elena.
Holland.
But the complication rate is quite high for Elena.
What is the name of the neurosurgeon?
We did also in Helsinki, so we had so many difficulties. We stopped that. We we stopped.
What is the name of
Yes, it's Elena.
Tulleken.
Yes.
Professor Tulleken.
Professor Tulleken. He come one time in Madrid, and the Elana, I introduced Elana in Madrid, in Spain, and every neurosurgeon like this technique, but I don't know why, never. I stopped this because probably it's not fantastic devices
The difficulty is to get the flap with the laser. So this is very difficult to use the laser to make the hole in the carotid or MCA, posterior cerebral artery. So you don't get the flap from the wall of the artery. So this is very difficult. So if you get only partially, then you have extremely many difficulties, and they like loving, they will come. So we did in Helsinki maybe 35 cases, and then it was given up. So like in most places. So in Berlin the same, and by Vygotsky happened the same, and many tried, like Ali Christ made one, gave up, and so it happened in many places. So in Sweden also, you were enthusiastic about the thinking that you don't have to occlude the artery, but the difficulties were many, and most gave up. Even the most skillful neurosurgeon, it was not the regular microsurgical skills, but I think only Tulleken and his successor learned to take the flap. So it needed a lot of cases and a lot of laboratory training, and so we couldn't manage, and so we gave up this one. So I think how Subin is doing, and of course here I see Li Ming Chao and Xiao Li, what I see in our hospital, they are extremely skillful. They have a big number of cases, and they were trained by Subin, so they are doing extremely well, doing 500 bypasses in our hospital a year. So this big number, and they have good skills and can do in the best way. Difficult to improve. So I think China can be extremely proud of Subin and his school, and should, like I propose in my lecture, learn English in China. So because you have huge number of wonderful cases, good neurosurgical skills, this means that you get more connections with the world, and it is not just getting famous, but getting the information and learning from other people around the world. So this is very important, the English language. So like Subin is world star now with his good English and presentations. And the same counts, Chao Liming is speaking English, just improve.
Okay, Juha, we'll end it on that, and thank you very much.
Yeah. Otherwise, we price ourselves too much.
Well, Juha, you speak at a lot of webinars. Is this your favorite?
This is nice because you don't have to travel anywhere. You have no jet lag. You are never tired, and just give your lecture, and then you are out of there.
Okay.
So you can say, I'm out of there. So this is very nice way.
You don't have to move.
Thank you for introducing me. Yes.
You don't have to move. Thanks, Hugo, for moderating, and thanks, special thanks for Dr. Bin Zhu, who's translated this into Chinese. And we'd like to welcome the Chinese medical neurosurgical community. Is there a topic for next week, Juha?
Yeah, I will speak about anti-communicating aneurysms, and we will find out in a couple of days.
Okay, very good. Okay, we'll keep everyone posted. So
Yeah.
thanks everybody, and we'll see you next week.
Thank you very much. Thank you.
Okay.
Bye. Bye.
Bye-bye.
Come to me now.
Thank
Yeah,
you.
thank you. Are you here, Clemens? I don't know if you're here, Clemens. Clemens, are you there? I guess not. So how'd the other conferences go?
Thank you so very much.
Okay, Dr. Daddy.
Okay, thank you, Dr.
I
John.
had a beautiful time, yeah.
Okay, Dr. Daddy, welcome.
Okay,
Yes, sir.
From Nigeria, correct?
okay, thank you, Dr. John, for the invitation. Okay, thank you from Colombia. Thank you.
Oh, Julian, you're from Colombia, correct?
Okay, Corey, yes, thank you.
Bienvenidos.
I'm from Lagos, Nigeria.
Lagos,
Bienvenido,
okay.
Dr. John, bienvenido.
Okay.
Okay, sí, señor.
Bienvenidos
Okay.
to Nigeria y Colombia.
Okay.
Is anyone
Sí,
else
señor.
want to say hello to Juha or to Ben or anybody? Dr. Z, because we're off the air now.